on Zoom? Oh, we'll have Zoom in here.
Okay. All right, we'll go on and call the meeting, Special Committee on Access to Quality Health Care to order. Appreciate everybody being here today. I know it's a busy day with multiple overlapping committees, and thank you for your commitment. We do have 3 bills we're going to go over today, and I'll begin with the first one that I'm the sponsor. It's House Bill 454. For anybody looking along, it's LC 338573. So members of the committee, this bill is a consumer-friendly bill. It really kind of piggybacks on some things we've done over the past few years with transparency, where in ways with hospitals and insurance plans, which people are paying between them and their employers $1,200 to $1,400 a month often for a family. We've tried to ensure through surprise billing transparency and other ways that when people and their employers are paying that much money, that they'll know what they're getting. And one of the key things about that is there is competition in the industry. We'll hear later from someone from the insurance industry. There is some brisk competition in that, which is good, but a big part of that, you need to have transparency, and you kind of need to know what you're purchasing. One of the ways a consumer does that, especially if you're on state health benefits or some other larger companies that offer multiple plans you can pick from, sometimes multiple deductible levels within a plan, but then also multiple different insurers or third-party administrators for ERISA plans. And one of the things consumers would like to do is they want to see if the hospital that they would go to if they need their knee replaced or if they want to have a baby, they'd look and see if that hospital's in network. And they do it by going to used to be a provider handbook that was handed out once a year and printed. And of course, that was cumbersome. They still, as far as I know, still offer those, but more importantly, they offer it online. So a lot of families will pick a plan based on my pediatrician's in network or my obstetrician, especially if I'm pregnant, is in network, or if I'm getting cancer treatment, I want to make sure that the doctor doing my cancer treatment is in network. And that may be a big part of why I pick a particular plan. One of the problems that's happened on occasion, and it's not real frequent, but it does happen, is that that oncologist, that obstetrician in the middle of my care gets dropped from the insurer's network. What we're saying is that since this was the information, what House Bill 454 does is it provides on lines 9 through 16 that the patient will be protected, because if an insurance plan drops a provider that was in their network at the time the consumer made the decision to pick that plan, or the employer, HR, whoever picked the plan for the patient and that family, that provider will be paid at in-network rates for the remainder of just that plan year. At the end of the plan year, it'll be up to the individual at the next open enrollment, their next opportunity to change insurers. And maybe at that time, they'll pick a different plan that still has their physician or provider or hospital in network, but they may change insurers. What it just assures is that if a consumer picks a plan based on a published provider network, that if the insurer removes the provider from the network, that the patient would still be held harmless, so to speak. They would still be treated as if they were going to an in-network provider that had been in network according to the published information from the insurer, and for the remainder of that contract year. And then once again, if they renewed with the same company and the provider was out of network, that special relationship would end, because it would be an informed decision then. And that's been a big part of transparency, and we do it every day in many areas, but in medical care in particular, informed consent does require that you have information. So if somebody's informed of something, this just assures that the patient will be protected from being treated as an out-of-network arrangement. I'll be glad to answer any questions the committee members may have. I know there's some that want to speak to the bill as well. Number 11. Oh, yes, sir.
Thank you, Chairman Newton. Only question I've got, this, and you might have covered it, the ERISA plans as well. Will it cover that?
Just like everything, if something is exclusively regulated at the federal level, it does not require the insurer. That's just the limit of almost all our insurance regulation. Representative Prince.
Thank you, Mr. Chairman. Is there anything that covers, and I understand this, and I think it's a great bill, good coverage for the consumer, But when that provider drops out of network, this bill allows that person to stay in it, that provider to continue to provide services until the next year, time to re-up or whatever. Once that provider drops out of network, will the insurer also offer in-network providers as an option for that consumer so that they may just switch to that provider, thus the next year it just continues?
You do bring up two things that, and one of which I failed to mention. That's a good question. That if the provider voluntarily or unilaterally drops out of a network, this doesn't apply. This doesn't apply if a physician group, or if you're getting care for, like I say, a knee replacement, you're pregnant and going to have a baby. This doesn't apply if the physician or the provider, the hospital or what other provider drops out electively. This is only if the insurer had them listed as in network and the insurer took them out of network. And then once again, like you say, though, at the end of the next year, you'll have choices. Once you're in open enrollment, the insurer, I'm sure, will have other providers in oncology or obstetrics that they could offer you, and maybe you'll change and keep the same insurance, but you might change insurance. But that next year is all. This only does for the remainder of the plan year, and it's peculiar to the fact that you're not allowed to change insurers in the middle of a plan year for most. So this keeps the consumer from being told that one thing was in place and then it changing, not from the provider side, but from the insurer's choice. Any other questions from the committee? I do believe we have, I'm not sure if someone, Jesse, did you want to speak to this? If you could introduce yourself and come on up to the mic, and then.
Yes, thank you, Mr. Chairman. My name is Jesse Wethington. I'm here today on behalf of the Georgia Association of Health Plans, which is the commercial trade group for Georgia's individual and small group commercial benefits industry. Our members oppose this bill as written. I'll keep my comments fairly high level. So one of the issues with this bill is that it would sort of upend the balance that we have currently in terms of negotiating our agreements with providers. This covers all practitioners or folks that we would contract with, but you typically hear about this in headlines every couple of years when a large hospital system will go out and network with a health plan. They'll typically, as a result of negotiations breaking down, not be able to get to an acceptable agreement for both sides. And then they go out and network, and then you kind of see this version of events play out similarly, where there's a pressure campaign, and then both sides, a couple of months down the road, come to an agreement after all and are able to get back into network. We would like for changes to be made to the bill, if possible, in terms of a provider making a decision to leave a network. There is some provisions around that for termination for cause. Many times there is no cause associated with it. It's cleaner for both parties to say, hey, rather than go down the road of having an adverse finding or taking a disciplinary action with the board if we find some sort of malfeasance or not the best kind of care that we would want for our members, we'll just agree that that provider will leave the network, and it's sort of a mutual thing that we don't think would be covered under the text of this bill specifically. Additionally, we have a concern about our exposure. When we are designing plans and building out our networks for a future year, obviously we want our providers to maintain their in-network status with our members. Representative Prince, to your question, of course, we would urge those people to seek care from in-network providers at that point until the two parties can reach an agreement, and hopefully that provider would come back into network at that point. This would have sort of upend the balance, as I mentioned earlier, in that there is no longer any pressure on the providers to come to a deal with the carrier at that point, because the member is held harmless and the provider is taken in a network rate. There are other provisions besides merely the rate that are involved in some of these contracts that relate to quality or having a national accreditation standard that we would also like to be able to preserve. So again, it's not just about that in-network rate, and we believe that the provisions in House Bill 888 from last year offer adequate protections for members. This is no longer occurring in the emergency situation because that was covered in that bill, and now you also have the ability, if you have an out-of-network provider, to get a good faith estimate for care that is non-emergent, planned, or scheduled. So for those reasons, our members are opposed to this legislation.
Those consumers, the patient in this case, would once they're out of network, then all the deductibles they pay, all the rate, even though they can get a good faith estimate for an out of network who had been listed as in network, they can get an answer, but it might not apply to deductibles. It might not, or it might apply to a much higher out of network deductible. The consumer doesn't stay protected, though. I guess that's one of the concerns.
Well, your bill would do that. Our concern with it is that we are probably at that point no longer pricing that consumer's premium or out-of-pocket cost sharing appropriately for the risk that we have for that patient seeking care out of network for the remainder of that year.
Just to clarify, the provider is going to still be paid at the same rate you would pay for one of those alternates that this individual could have chosen. An alternate obstetrician is going to get paid in-network rates, and this one that was listed in network, but now you've dropped them out, is going to get paid in-network rates. I'm not sure how that's going to harmful.
I was referring to the consumer's out-of-pocket cost sharing amount, which is limited to what it would have been in network under the provisions of this.
Yeah, it seems like both the consumer and the insurer are out the same amount of money, and frankly, the provider
If the consumer was seeking care from any other out-of-network provider, they would potentially have a higher out-of-pocket proportion as an element of their plan design. So that's kind of the differential in what we would price that person's premium for an upcoming plan year with their anticipated out-of-network utilization versus what they could now actually do while being held harmless with a provider that had gone out of network in the course of the plan year.
Okay, did you have a question for the presenter, or want to speak?
Just
Go ahead,
a
Chairman.
clarifying question to the chairman, and then if maybe to the presenter. But I want to make sure I'm understanding your bills are probably addressing some issues that I think have happened in Georgia. Is that correct? With all of a sudden midstream in the middle of a plan year, not going into the plan year, but in the middle of a plan year, all of a sudden there's just a shut off. Is that what this is? I want to make sure I'm.
It is, and while, as you mentioned, the large multi-lawyered groups go head to head, large insurance, or maybe a large healthcare system, who gets left in the middle is the patient, who now is trying to figure out what to do, where to go, whether to stay out of network and have huge deductibles and out-of-pocket costs, whether just to change care in the middle of even a treatment plan that's active and ongoing. As it said, in oncology or obstetrics are the two most, I would say, egregious examples of forcing someone to change. And the bill was careful to try to make sure it didn't cost the insurer any more money either. As you mentioned, the actuarial approach, the fact that they're still only getting in-network rates. It's not like this bill will not require an insurer to pay listed charges or some out-of-network rate or something that might be considered exorbitant. It's no more than they would pay to any of their other listed in-network doctors that the insurer didn't terminate. So I think there was a degree or an effort to protect the insurer. Yes, sir.
Well, and I think, thank you for helping me clarify in that. But I guess my question goes to the presenter is these circumstances that are examples that we've had in Georgia have occurred not even around the beginning of the plan year, but if I'm not mistaken, and Chairman, if you'll correct me, but in the middle portion of a plan year, which would infer to me is that you had a contract or an understanding going into that plan year, and all of a sudden you wanted a change. So, why all of a sudden are you saying I want to change? And I do understand one group had a change, and y'all not necessarily, I don't know what particular insurance company it was, but they came in and just demanded a large slash in the amount. So I just wanted to make sure it seems irregular that you go in midstream and change a contract.
So in response to your question, Chairman Knight, our member plan year contracts are on a calendar year basis. All of our provider contracts are not on that same 12-month calendar year basis. And so you're just going to have time where the contracts come up for expiration. Both parties can't reach an agreement about how to have a continuing relationship going forward, and so they go out of network. I'll tell you, that hospital that rejected the contract for the large slash probably had a corresponding large increase that they had requested, and so that's just part of the bargaining process between the hospital and the insurer at that point.
Mr. Chairman, just one follow-up question, if I may.
Sure.
isn't that an inherent conflict that if you've got your members on a calendar year in sort of a calendar year plan, but then your providers on a on a mid-year plan, isn't there conflict and where
There's typically a
uncertainty?
multi-year, 3 or sometimes even
Yeah, that could
5-year
certainly be more
provider
than 1 year.
contracts that many of them have evergreen clauses that just go on for a decade or so. I mean,
But why wouldn't you marry those up so that you have some
Practice in the industry
continuity?
here, I can't explain to you the origin of that practice, but heretofore in the industry, that just has been, how it's been done.
Chairman Nix.
I think you just got to the question I asked. The plans are not corresponding to the plan that I buy into doesn't necessarily correspond to the plan that you have or the agreement that you have with the provider.
Right. We have to provide a provider network in our directory during the open enrollment, and that is a snapshot in time of the network. And so for various reasons, providers fall out of the network over the course of a calendar year. Obviously, we would prefer for them to maintain a network contract and serve our members at a better rate, but unfortunately, we're not always able to accomplish that through negotiation.
Okay, so that's exactly what this bill's kind of getting to is you don't get to sell me a plan on January the 1st that says you're going to take me till December the 31st, and then on June you get mad at the provider, it doesn't work out, and then suddenly I'm the one that suffers. That doesn't. I kind of like the idea of what we're trying to do here. If this is what we're trying to get around, right?
It's what we did through a lot of that surprise billing. We're trying to take the patient out of the middle by having the larger entities, while they can still disagree vigorously and they can negotiate vigorously. This seemed to be a balanced way to limit the insurer's exposure by keeping it at in-network rates, not requiring them to pay out-of-network rates for the rest of the year. So no more than it would cost to go to some doctor they didn't, or hospital that they didn't kick out of network. But at the same time, who gets protected, and the physician or provider or any provider really, they don't get to charge out-of-network rates either. So it seemed to be a balanced way to protect the interest of the insurer, but the main thing was to protect the interest of the patient who bought into a plan. Yes, ma'am.
Let me
Chairman.
just finish.
Oh, sorry, go ahead.
It seemed like it would be simple enough to sync those plans up a little bit, though. Somebody could work on that just a little bit and sync those up so that you don't have that 6-month or 3-month break there. That seems like an administrative thing that could be fixed a little, that if they really wanted to, they could fix that.
Yeah, that's not something that we've talked about in the industry since I've been involved with it, but that's an interesting topic for discussion.
Okay, thank you.
I'll
Thank you,
take that
Mr.
back to our members.
Chairman Houston, did you have a question for the presenter, or?
Suppose you had a provider that wasn't living up to the contract and giving the standard, and you didn't feel comfortable about keeping them. How would you ever get out from losing that provider?
We would have to terminate for cause. It typically involves some sort of a proceeding where we have to demonstrate that cause. As I mentioned earlier, typically it's quicker and easier for both parties just to agree to part ways without a finding, because that is involves less of an expense in terms of demonstrating that the provider didn't meet some standard.
Well, if you ever terminated a contract with a provider, wouldn't you always have somebody hanging out?
To come in network, or
It means if you wanted to terminate somebody at the end of your contract, wouldn't you always have some people that were insured that you were supposed to take care of? How would you ever sever your relationship with the provider?
at that point, those members who are seeing that provider would be, currently, should this bill not pass, those members would have to pay an out-of-network cost-sharing amount, and that physician would be reimbursed at an out-of-network rate.
And the physician would be reimbursed at an out-of-network rate?
Currently.
I remember I was at one in Cobb County that, people went for a long time before they couldn't decide on the contract.
Correct, and that happens. You'll see that play out every couple of years, where a big hospital system will go on the network with somebody for 2 or 3 months, and then they'll come back to the drawing board and reach an agreement eventually. Sometimes there's a contract provision that allows them to be held harmless. That happened, for example, in the SHBP a couple of years ago with a large Metro Atlanta hospital system that fell out of the network for a few months. They were allowed to basically do a version of what this bill would do, which is pay the in-network rate and in-network cost sharing for members. The exposure to the SHBP for a few months of that was $50 million additional dollars. So these do add up quite quickly, and the differential between an in-network and out-of-network claim.
Chairman Parrish, did you have a question for the presenter, or?
Chair, really, for you, I think I understood you to say, and I just want to make sure if I'm correct in this, that basically the insurer is not going to be out any more money than they would have been paying because they'll just continue to pay at the in-network rate until the end of that contract. Is
To
that
the insurer, it should be identical to as if the patient did change,
Change.
for example,
To
change
someone who
physicians or
was in the
change,
network.
Healthcare. It really is, I know they want more control than that because there's more than just the rates that an insurer wants. This does address quality challenges if somebody was out due to a suspension or revocation of a provider's license. So it did try to address that. And I understand your networks are not just price networks, but they're also quality measures that you want to keep. And I appreciate that. But financially, the insurer should not be out any more than if the individual, just for the remainder of the plan year, and like Chairman Nix mentioned, it may just be 3 months left, but for just the remainder of that plan year, they would just be treated financially. The insurer would pay the same amount out, and the patient would pay the same amount, and still get credit for the remainder of that plan year only for that. But thank you for your presentation.
Thank you, Mr.
I
Chair.
think there's others that did want to speak. Was there other? We did have several sign up, but I know some may have signed up for alternate bills. Was there anyone else who had? Come on up. That's fine. You can just go ahead.
Hello, everyone. My name is Bethany Scherer with the Medical Association of Georgia. We represent over 8,000 physicians across the state of Georgia. This bill came up as part of sort of our policy-making process, and it was brought to us by physicians who were concerned about their patients having sort of not getting this sort of bait and switch situation where they sign up for a health plan thinking their physician was in network and then it turns out they're not. This is especially important, I think, as Dr. Newton has mentioned, to patients who, have a preferred obstetrician or patients who are seeing an oncology provider. This can be incredibly important to them. And I also want to bring up that we have had a lot of issues over the past few years, probably about 5 years, since the federal government started looking at the surprise billing legislation, that has led to insurers offering sort of take it or leave it contracts to physicians. So they don't necessarily kick them out of network, but they create a situation where they either take a very reduced rate or they're out of network. And these can sometimes be like 50% rate cuts. They can be, massive cuts to their revenue. And so that has been an issue that we've seen sort of ongoing, and this creates a situation where patients never know who's going to be in their network. And it does lead to these negotiations that can sometimes be really difficult for patients to figure out because, there are rules that prohibit physicians from talking about the rates they're getting. So obviously our physicians can't talk to each other about what rate they get from what their rate is compared to somebody else's rates. We don't know any of that information. So I can't answer questions about specifically whether costs would be the same between one in-network provider compared to another. But I can say that our physicians are doing this to try to protect patients. It doesn't necessarily help all of our physicians because at the end of the day, oftentimes the out-of-network fee that they would get if they saw a patient out of network would be higher than what they would get for their patient being in network. So because they can bill the patient after the fact or set up a fee schedule to get money directly from the patient. So this really is about protecting their patients and making sure their patients have continuity of care with the physician of their choice.
Thank you. Thank you.
Thank you.
Don't see any questions. And I don't believe there was anyone else signed up to speak to the bill. I'm sorry.
Very briefly,
Greg, sure.
Mr. Chairman, Greg Reibold on behalf of the Georgia Pharmacy Association, and we are in support of this bill. We think it strikes, an appropriate balance and really puts the patient first when you're thinking about access to care, continuity of care, and transparency. We think it checks all three of those boxes and strongly in support.
Thank you for your testimony. This time, what's the pleasure of the committee? Who do we have? Go ahead. Do pass. Okay, we have a motion to pass. In a second. Is there any further discussion from the committee? If not, all in favor, aye. Aye. All opposed, no. The bill passes. All right, we will move right along. Thank you for your participation, and thank you. House Bill 447, Chairman Knight, will you, it's also a very short, very brief,
Thank you, Mr. Chairman. I dropped this bill about over a week and a half ago, I think, and so, been very open, as far as, people talking. Obviously, in the last day, a lot of folks have come in and just want to talk at the last minute, but the bill has been out there. There has been some concerns, and I do want to go ahead and address some concerns on both bills. As far as what it applies to, and I will ask at the appropriate time on each of these bills to insert language after on line 17, I think it's 16 of the other one, or 18 of the other one, but board with the contracted entity, and I'm going to ask for an amendment that says adds in licensed under Title 33. There's been a lot of concern out there. But both of the bills have almost identical language. Yeah, and we're working on 447. On that one, it would be line 17, and after the word entity, at the appropriate time, I'll ask the committee to consider a friendly amendment that says licensed under Title 33.
which restricts it to
Insurance.
insurance.
Yeah,
Right,
that's
okay.
that's the code section that has insurance. So I wanted to make that clear. I heard from a lot of our providers across the state of concerns there, and so I wanted to make sure that we address those concerns up front. If you will, slide. Yeah, or and a board, but basically, I want to talk about, before we get into the slide. 447 only applies to the state health benefit plan. That's the code section here. And the state is probably the biggest employer in regards to employees needing a health benefit, health insurance. And we as a consumer, okay, we have a right to enter into contracts and know the cost and all of the information before we enter into it, because we have I think, an added responsibility. And that added responsibility is that we are using taxpayer dollars, okay, to pay for these health benefit plans. There's also another responsibility that we have, along with every other employer who has a plan, but to make sure that we also protect the ultimate consumer, which is the member, potential patient. I think your bill spoke to that, and it was getting at that, trying to hold that patient, that member, harmless. But that is where we're going with this. And not only are we seeing the cost continue to increase in the state health benefit plan, but I'll also remind you, on the side of the member, we keep seeing an increase as these costs increase. What's the part that's passed on to the member, the patient? There's higher cost. As the cost goes up, a portion of that higher cost is borne by the member. And so we've got a responsibility there. This was a slide from our joint budget hearings just a few weeks ago. And it was really shocking to look at the increase in the cost of the plan. And we look at the cost from 19 until now, the 22 proposed plan, and it's almost $395 million in increased cost. But what gets me is, as you look out in the future years and these projected costs, and it is absolutely astronomical, the amount of money that every year is put in our budget, and we're basically, signing a blank check. I've said that before. And I think we as a consumer, as the state, have a responsibility to make sure that we understand the underlying cost, not only as members of the General Assembly, the committees, but the taxpayers also, the funding this, should have access to basic cost-related information. And so that's the premise of this bill, and what we're asking for on behalf of the state is basically that cost data. In this, you read the word spread pricing, and you may think, oh, we outlawed that, and we did. We found that in our prescription drug side of the house. But we don't know if that's happening on the health benefit side of the house. So like that, all of these data points are cost-related data that I hope that we will make sure that the state, through our contracting entities, are taking into account the real cost data as we enter into these contracts. And I'll remind you, the state spent, or is proposing, $3,745,000. $3,745,279,000 some change is what our budget is for this proposed coming year of the state health benefit plan. That's a lot of money. And so basically this bill, makes sure that DCH, from a contracting perspective, cannot contract away their right to obtain and examine cost-related data. And that's basic information that's necessary to manage healthcare costs. And it leaves no doubt that this cost-related data is not confidential, nor is it a trade secret. The bill also makes sure that personally identifiable health data is not subject to disclosure. And that's simply the bill.
All right, thank you for your presentation. Are there questions from the committee?
I got a question.
Yes,
Yes,
ma'am.
ma'am.
Talking about cost data, are you talking about what it really costs a hospital to do that service, or what the
Hospitals are out.
No, the hospital, this is the insurance, because remember, the insurance,
But they have to pay the cost of the service.
well, what is the cost of the service from an insurance point of view that is billing or
Well, how much
the
is the
state?
hospital charging them for that?
Well, we're not going after the provider part of this. We're looking at the piece from the insurance, which should have some of that data of what they're doing. But it also should have the data of what the state and its plans and its members are being charged versus what the insurance is charging back to the state or requesting a remuneration of cost that either from the state or from the from the fund.
So you're going by the cost that it does to provide the service.
No.
Is it what it costs the insurer?
It's
What
the
it costs the
insurer.
insurer
It's the
to provide the
insurer,
service,
yes.
to make
Yeah.
sure that they really, if they turned a bill into state health benefits for $1,000 for Hospital X, that Hospital X actually got $1,000, that the cost that they're reporting to the self-insured health plan is that correct?
Yes,
Is that what,
that is right.
is that it? So,
But there's a big difference in what they charge you and what it really costs for the hospitals to do it.
But I think we're getting into a transparency measure that we're looking into those things. We have started looking into those things. And this is another part of the transparency piece, because the link between the state and all these providers is who? It is the insurance companies that we contract out with.
Well, I hate to ask these questions because y'all know I had some dealings with insurance companies in the past. But,
I don't know if I'd repeat that, but no, I'm
well,
just
I
kidding.
don't mind repeating it. But the thing about it is, I wonder how you would, if everything's out in the open, how do you bid on I mean, I used to play bridge and I didn't want to show all my cards. And I just don't
Nobody's
know-
showing all the cards, but I think going back to the issue,
I just don't know how you'd if you're bidding on another insurance company coming in, how would you bid against each other? if everybody knew all your tricks.
Well, you're getting into a trade secret issue that's fine, a secret sauce, but ultimately cost, okay, and what's being billed for, billed to the state is a different issue, okay, versus what they're paying out or what the charges that are going back. And so,
If they're charging the state too much, why don't you go to another insurance company and do this?
well, let me ask you a question, Chairman, okay?
Okay.
We've hidden, and we're under a healthcare system that forever is a non-transparent, opaque, convoluted, confusing system. And if we want to talk about a free market, okay, and we want to talk about innovation, when we have people who can look at cost and the underlying cost, I will tell you that the price of gasoline, you can almost within pennies go back and break apart the cost of a gallon of gas and understand where every part of the cost input is, okay? But these trade secrets that you keep talking about or you're inquiring about, okay, are exactly that. Nobody understands the true cost of health care. And it was just like with the prescription drugs that this General Assembly has started looking at and finding where the cost, okay, of a drug and what was reimbursed to a provider was less than what they charged to the state. And all this is making sure that our state has the right data to enter into these contracts. For instance, spread pricing. We found, if not for the work of this General Assembly, Chairman England and the late Jack Hill, that put in the 918 line language into the budgets, I think it was 1718 or 1819, that these contracts that the state had entered into on behalf of its citizens, that there was spread pricing in excess of $50 million one year and $45 million the next year. So that's what this is trying to get at. And when we make sure that we have the underlying cost of health care in Georgia, we can make better contract decisions. And we also can open those contracts up, because if we're going to stay within this closed, secret, behind the curtain, proprietary and secret information, all right, what it's doing is it's not allowing innovation. We've heard in committees in the prior 2 years that there are companies that are willing to come in here and do this, not based on this secret model, but to do it out in the open, and to do it in a manner that's transparent, so that everyone understands what the cost is. And I'll ask this one question. Under the current model we have we seen any decrease in the cost of health care? And the answer is no, whatsoever. Our families,
You think it's all the insurance companies?
I think that is a big part of it. Yes, ma'am.
Well, when I see what it costs to do something in the part that they charge me when I go to the hospital, there's a big difference.
Because that is behind the scenes of contracts that you can't see. And that's what I'm trying to explain to my friend, is that what you don't see behind the scenes is what we're trying to get at, is some underlying cost issues. So,
If we do this, we'll still have a lot of insurance companies coming out with.
well, I've heard that, people will not want to do this, but one, we are the largest employee in the state with better than $3 billion, approaching $4 billion of cost. So for them to leave the state, I think that would be probably unrealistic. Second thing is I think that this allows for people to come in here and us to look at data and maybe innovative other ways to look at health care, and would invite people to the table that want to be transparent and want to make sure that the data is there, the cost data is there, so that not only the state can make good decisions, but the the patients or the members can make good decisions. And most of all, we can be good stewards of the state tax dollar.
Can you clarify something for me? I know when a third-party administrative health insurer, especially we're self-insured, and those fees just come straight through. And I'm reading about price information, negotiated rebate accounting, which is where are you saying that somebody could turn in a bill saying the cost was $1,000 and then get a rebate from the entity that provided it, whether it was a pharmaceutical or whatever, of a certain amount, but they still turned into the state
Yes.
a cost of $1,000, even though there was a $400 rebate
Yeah.
that came later? Is that one of the goals, is to get to you almost would call it a true cost?
Yeah,
is
we're
what you
getting
wanna
down
know,
to the
not
true-
the
the-
list
the-
price
yeah.
that was rebated.
Yeah, because everything is dealt with on an artificial inflated MSRP, and you're exactly correct.
It'd be illegal for a
Chairman.
hospital or provider to pay a kickback to an insurance company. They would there's their cost, and there's a negotiated rate, and that's the rate that gets paid, and that's the rate that gets reported to state health benefits as needing to write a check for. But I don't believe rebates exist in the hospital and provider area.
Well, who knows though? And I
Well,
use that as an
That would
example.
be a way, yeah. If
But
somebody is, we need to know.
my question is, who knows what is there? We didn't understand what was going on within the prescription drug benefit side, and now all of a sudden we're still learning on that side. So why does a $18 drug that ends up being the true cost of a drug get billed back to the state at $1,000? Okay, and why are co-pays and co-insurance and things being from the patient being applied at the higher rate than what the true cost is? So we didn't know all these things until you get to the true cost of what insulin is. When you get to the true cost of what, the cost of providing that health care, whether it be through a drug and a procedure or a medical appliance, we will never, ever, ever solve the problem of never-ending price increases in healthcare. And I just, it's at the state, and you can look up there. That's what it's projected. Where are we going to get the money?
Chairman Perkle.
Thank you, Mr. Chairman, and I'm going to be quick with my question, and I clearly do not have an expert knowledge in this area, and I'm going against Granddaddy's advice. Better to keep quiet and let them think you're dumb than to open your mouth and remove all doubt. But I can divide. So of $3.75 billion, how many members does that cover?
I'd heard 600,000 at one time, but I don't know if that's actual employees or if that also includes family members and dependents.
Okay.
All covered lives is about
600,000 covered lives.
Okay. That's math that I can do.
That's a lot of digits on your phone calculator.
It
there.
is. I had to turn it sideways. Other than E9 can throw you off. It's been several years since Georgia Tech, but we are self-insured.
Correct.
And I want to find out the basis for why we're doing this. So when I enter into a contract as Perkle Farms, and I'm covering the cost, and someone is providing a service, I could normally just ask them, I'm paying you for this. How much is it going to cost me for me to pay you to do this? Or is that the cost that we're trying to get to? And secondly, this information that we're requesting, it says in line 18, shall include provisions requiring such contracted entity to disclose to the state. Who exactly would that be disclosed to? Is that one way that we can get around the concern that has been expressed that perhaps some of these costs have not been disclosed to us who are paying the bills, and that they could go to an entity within the state that holds trade secrets that can ensure that we are not, there again, I am not as well versed as all the other people that have spoken on this, But I was just trying to gain an understanding of if we're paying the bills and we ask questions, what can be revealed now and what we will get later?
Chairman Perkle, that's a great question. I did extensive open records request in the prior year with DCH. And quite frankly, everything I got was redacted. And so the contracts that the state is entering into, we know, or at least we've demonstrated that the work of this General Assembly and the things that we've done to try to curtail the cost, try to make sure that quality health care is affordable, but we've got good health care outcomes. And quite frankly, we can't see any of it. And I'll go back to, again, the prime example that we've got that I know was the spread pricing. And so, that was an issue in which, unless, we had done something, had not done the 918 language, the contracting entities for the state, in this case DCH with the state health benefit, and that wasn't where it was in Medicaid, okay? But we would have never found that. And again, nobody knew what was going on. And so that was where there was issues, and that's what we're trying to get at today, is that we know that within the healthcare world, and all of it, that nobody knows the underlying price. And what's being controlled is via the contracts and the vertical integration within the healthcare and the health insurance companies that are not only contracting out to providers, independent providers, but I would tell you that are also contracting with their subsidiaries that are also moving into the field of healthcare. We've seen that where the vertical integration is moving into pharmacy. Okay? We've proven that. You've got health insurance companies that own the brick and mortar on the corners, the specialty pharmacies. That's the steering part that we try to get at. But what are their costs? And what are they turning around and billing us? And what you're seeing also is that now the insurance companies, and you go read their financial statements, are moving into healthcare. And they're forming healthcare companies. They're buying up physicians' office. And this is not something that's new. The federal government is doing this. There are federal, the feds are requesting data information, and they're getting concerned. So again, I want to draw this back to this is you can sit here and overcomplicate this all you want, but until we get the underlying cost data and those data points so that we can enter in as a sophisticated buyer, okay, on behalf of all of the people of the state of Georgia that we are responsible for health care, we're not going to be able to make not only good choices with our money, the state's money and the taxpayers' dollars, but we're not going to be able to make good choices as far as those contracts and what it locks them into and the choices it locks them into their options of health insurance.
Representative Prince, do you have a question for the?
Well, yes, and again, it's probably going back to Chairman Alston's, and forgive me for my layman's approach on this, but basically we're asking contractors who contract with us to give us all this information. It's based on data, pricing, and all this other stuff.
Mm-hmm.
Do we not just put out, for lack of better words, a request for proposals, RFP, saying these are the services that we want? This is what, and then as bidders, insurers, I'm assuming here, they bid on this, and then.
We do.
Okay,
But if
so
you go
once-
read some of the requests for proposals and read some of the language, you'll end up finding out that those requests for proposals are very closed, and they limit the amount of people who are eligible to turn in bids. Okay?
But that's us as the state. That's us.
With this, it absolutely starts to get at the data, okay? And it starts to get at the data so that we can make the good decisions as far as entering into $3 billion worth, or almost approaching $4 billion a year in healthcare costs to the state. And I would argue to anyone, why is transparency a problem?
And I'm definitely not saying transparency is a problem, because that's what we want. However, if I'm going to bid out a service, I'm expecting contractors to give me a price on what it costs them to do it. Now, how they do it and all this other good stuff, I don't need to get in the weeds on that, as long as they provide the service that I need. And another concern I have with the open records, somebody has to know this. Whoever does the RFP, I'm assuming is the state, because we're the ones putting out the contract.
No, they don't. There are instances that even within there that they don't get all of this, okay?
Okay.
They
well,
don't get all of the information. It is locked up, audits and everything else, and the consultants that surround this ecosystem, everything is held to the chest. Everything is held privately,
By-
okay? Within this ecosystem of the health insurance companies, okay? So you know, we go back to, again, prescription drugs is a huge part of it. So let me ask you a question. You have a prescription drug benefit side of the house, right? That's separate. And you have a healthcare side of the house. So you're a patient, you're on the state health benefit plan, and your deductible for drug X is, I don't know, $20. So you go to the hospital and you get that same drug. Are there rebates on the drugs for the drugs that were issued or prescribed within the hospital? Who knows?
Well, no, I don't. But what I do know is I got to pay $20 for whatever that is. And because that's what the contract says, that's how much it costs. We're into this contract, and that's where and again, maybe I'm probably missing something here, but, so, again, I'm just trying to.
We do have some that to speak. Maybe some will bring some clarity, or maybe we'll be more confused. I don't know. But let's go ahead and get started. I guess we'll, Mr. Wethington, did you want to come back and start?
Yes, thank you, Chairman. I will reserve my comments to House Bill 448, which is the Medicaid bill, but they generally would be applicable to both. They're very
Just,
similar in terms of the
just
approach.
for time's sake, or
It's the same-
The,
it's the
the
same
bill's
language.
the exact same language. It just applies to two separate, and this is, I believe, a much smaller. Is Peach Care for Kids is ballpark?
And low-income Medicaid as well. So that's, the Title 49 bill would be the whole Medicaid,
Oh, well,
low-income
that's
Medicaid and Peach Care for Kids program,
Well, that's
correct? Chairman Knight?
It would be the I believe the managed care part of it,
right.
or
The MCO
Yes,
portion.
so,
Okay.
I'm here today as Executive Director of the Georgia Quality Healthcare Association, which is the trade group of Medicaid managed care organizations. We oppose House Bill 448 on the grounds that this would expose our trade secrets and proprietary and confidential information to public disclosure. To Chairman Knight's point, if transparency is good, then I would urge the committee to reject the amendment and apply this to all healthcare services and contracts issued from DCH. You know, what's good for the goose is good for the gander. Can't help but feel a little bit singled out here in terms of my industry. In terms of the specific issues in the bill, you know, having this go out the door is not going to let us do what our mission is, which is to drive a good bargain in contracting for the state. You know, I would applaud my friends in the provider community for their lobbying on getting an amendment to get taken out of the bill. I can assure you all that we will send your confidential and proprietary information out the door with our negotiated rates, because we have both of those as well. Really what I would ask for this, we already provide a ton of this information. CMOs are probably the most regulated and accountable entity in the commercial healthcare space. We have 65 reports that we have to give to DCH on a periodic basis. Some are annual, semi-annual, on everything from our legal practices to communications that have to be approved before they go out to members, to spread pricing reports. A lot of this information is available in aggregate. I understand the frustration of the General Assembly in dealing with some of these. I have experienced this both at the agency lobbyist side at DCH, when I worked on staff in your budget office, and now from the advocate side for the contractors. So I get your frustration. I understand all sides of this argument. we are not going to be able to drive a good bargain for the state if we are negotiating with a third party. That person could open records request our negotiated rates with a similar provider down the street and say, hey, you're paying X hospital for this, I'm just as good as them, I would like some more money too, for the same service. Our request for this would be to delete the last sentence of the bill, which would allow us to maintain our confidential and proprietary trade secrets and information.
You mentioned including other providers like hospitals. I believe the federal government, CMS, and hospitals can speak to this, starting January 1st, 2021, is required to provide clear, accessible pricing information online in a comprehensive, machine-readable file. This was I think this wave of transparency, if you want to call it that, or tsunami, if you want to, depending on your point of view, I believe the hospitals are already having to, if I'm, you can correct me if I'm wrong, but reporting
that's
that.
master data, so that's not.
Actually, it was supposed to be their insurance
reimbursement
payments. Actual reimbursements was what was so controversial about it, because it was the first time ever to actually have to give those. And I believe they fought them under trade secrets, but I don't believe it was successful. And I believe that transparency is coming. I believe others are probably looking at similar red ink the way we're showing up there for the state health benefits, and I'm sure it's probably the case with Medicaid as well. I think there's others. Hospitals, I believe, are being included in transparency, just not in this bill. But I believe they have a lot of transparency they're having to do.
And transparency being a good thing, we would say that it would be good for everybody. And we would want that to apply to all Medicaid providers, even ones that are directly contracted with the state. Again, there's a lot of money going out on the fee-for-service side. To be a good steward of the public dollar, I would expect that you would want to have that information as well. In terms of some of the specific information, we abandoned spread pricing in the Medicaid program voluntarily before we were asked or required to do so. I have the press release where we put out a joint statement with Georgia Pharmacy Association in 2018.
Is that in the Medicaid and the state health benefits?
Like the state health benefit plan, I can't speak on behalf of an SHBP TPA because I don't represent them, but
Okay.
there's no spread in that contract as well. I can't tell you the effective date of that, but that has also recently
Go
occurred.
ahead.
And to the issue of cost, what you are getting from this bill, if it is limited to only insurers, is reimbursement data. You're not getting any cost data about the cost of delivering a service in the hospital or the doctor's office. You're not getting any data about the expense of the drug. It is limited to what the insurance company has negotiated to reimburse. You are ignoring a whole side of the cost equation with this and only focusing on the reimbursement rate from the insurance company.
There's more to it.
Any questions for the presenter? Thank you.
Thank you.
Scott LaFranco.
Thank you, Chairman Newton, members of the committee. My name is Scott LaFranco. I'm the General Counsel and Vice President of Government Affairs for the Georgia Dental Association, representing over 3,500 licensed dentists and specialists, pediatric dentists, Medicaid providers in the state. I think one of the points maybe that I can help clear up with some of the questions that you got regarding, well, this is a contracted amount, we're going to know going in what we pay for the service. The problem with that argument is that you actually don't know how much of that money is being spent on care and how much money is going in and being kept as profit and overhead. And that's exactly what this bill is attempting to do. It's attempting to distinguish a loss ratio, how much money the state is paying in taxpayer money for insurance, and then how much money the insurers are keeping as overhead and as profit. So you actually don't have an idea of how much money is being, for example, in dentistry, we're a subcontracted relationship. So the state has a relationship with the MCOs, Department of Community Health. However, those MCOs subcontract the administration of dental benefits to what we call DMOs, dental management companies. The state has no idea how much money is being spent at the dental level because there's no privity of contract between the state and the dental management organization. There's no contractual relationship there. So it's exactly what Chairman Knight is alluding to. There's gaps in the amount of information that y'all are being able to see from a budgetary perspective. And perhaps the CMOs and the DMOs are actually doing a good job, but you don't have the metrics to evaluate that. And for that reason, Mr. Chairman, we fully support this bill. And I'll be happy to answer any questions of the committee.
I see Oh, sorry, Chairman Houston.
I think my dental bill's gone up as much as my hospital bill's gone up. I don't know about anybody else.
Sure.
Thought I'd throw that out.
Well, the cost of care, yes, ma'am, have gone up.
Thank you.
Thank you for your
Thank you.
testimony. Greg Rybold?
Thank you, Mr. Chairman.
Sure.
Good afternoon, committee. On behalf of the Georgia Pharmacy Association, we strongly support this piece of legislation. You know, look, these are tough issues, and, you know, from my perspective, change is hard. You know, improving things are hard. And when you talk about, you know, just massive institutionalized healthcare spending, and we're talking about contracts that are billions of dollars, more than I make in 2 years. No, I'm kidding. But, you know, massive amounts of money. And the status quo is easy, right? It feels right. Things are going along. And every now and then, you know, somebody puts something like that up and you realize, you know, where is the status quo getting us? And, you know, from my perspective, transparency is a catalyst to change. You know, it can lead to change, and at times it can compel change. And we've seen that, you know, particularly with regard to prescription drugs. I think, you know, look, this chamber, this body has done some awesome work dealing with prescription drugs and abuses of pharmacy benefit managers. I think there's more work to do, certainly. But, you know, from my perspective, if you want an example of what transparency can do, and Chairman Knight, Representative Knight, you know, alluded to this, but was the spread pricing, right? We knew that prescription drug pricing was getting warped in Medicaid managed care. But what do you do about it? Right? It had gone on for years and years and years, and it took this body to get to transparency, not the department, this body to put in the budget, hey, we want a report to see what spread pricing is. And lo and behold, in 2018, the state overpaid for prescription drugs by $50 million. That's a shocking amount of money, right? The next year, a little better, $40 million. But, you know, that transparency is what it takes to lead to change, to lead to efficiencies, to improve access to care for patients, to improve the cost for taxpayers, right? You know, good friend Jesse Wethington alluded to the Pharmacy Association and his association working on the spread pricing issue. Well, guess what led to that? That report, right? This body exposing the games that were being played in prescription drugs. And, you know, we found out the next year, you know, and I get it takes time to do, but, you know, spread was still kind of there. And what happened? This body took action and prohibited spread pricing on state contracts, right? You got a Medicaid actuary study that comes back and they say, and last year also the budget office, yeah, removal of spread pricing is going to save money. It's going to save the state $40–50 million. You can't fix it if you don't know about it. Another example, steering, right? We uncovered through open records and access to publicly available data that there was significant amounts of patient steering in the state health benefit plan and in Medicaid managed care. Sick patients, patients with cancer, patients with HIV, chronically ill patients, patients with diabetes and high blood pressure, forced from their providers and forced to use mail order or specialty pharmacies that were owned by the pharmacy benefit managers themselves, right? That's what was going on. You all fixed it. You all fixed it because you had the data and the information to make that change, right? And I think, you know, at the core, that's what this bill looks to do, is it looks to increase transparency. There's a lot of work to do, right? And this is going to give the access to the records and the data to do that. And so, again, Pharmacy Association strongly in support of this legislation, would ask for your favorable consideration. Thank you.
Thank you. I don't see any questions at this time. Cash Trivedi.
Thank you, Mr. Chairman. Cash Trivedi with PCMA, the Pharmaceutical Care Management Association. We're here to respectfully oppose House Bill 447 and 448. As you guys know, you guys passed sweeping PBM legislation last year, much of which hasn't even gone into effect yet. Doesn't go into effect until July 1st, 2021. You know, the reason we oppose is including new disclosures and transparency mandates on any entity that contracts with state health benefit plans or Department of Community Health. If passed, these new mandates would create a competitive disadvantage for any entity with a state contract. As written, House Bill 447 and 448 could result in private entities who have no rational experience bidding in state businesses to withdraw from the Georgia market.
Any questions? Thank you for your testimony. Skin Edge. Thank you for being here.
Thank you, Mr. Chairman,
Go
members
right
of the
ahead.
committee. Good afternoon, and I appreciate the opportunity to be before you today. I'm Skin Edge, and I'm here on behalf of CVS Caremark. Caremark is the pharmacy benefit manager that is owned by CVS Health. I'd start off my comments by asking, just for a point of clarification, maybe from Chairman Knight. He mentioned with the amendment he only wants this bill to apply to insurers. Do I take that to mean you do not want it to apply to pharmacy benefit managers?
Anybody that is up under that code, the Title 33.
Okay, all right. I thought that would be the case. I just want to be clear on that. You know, while the goal of transparency is usually a laudable one, sometimes you can go a little too far in trying to achieve that, and I think both 447 and 448 are examples of that. There's been testimony that the bills only deal with cost data. That's what they want to get to, is the cost data. I would submit to you, if you look at the bills and you look at the information that's being requested under these bills, it goes far beyond cost data. It gets into quality information. It gets into claims payment, how you handle your claims. It gets into your profits. So if you are any entity titled under Title 33, you're going to be required to turn over that information. You're going to be required to turn it over not only to the state and the General Assembly, but it is specifically in the bill made available under the Open Records Act to anyone and everyone who wants to make a request, including our competitors. We have been representing the State Health Benefit Plan now since 2018. During that time, we have been transparent. We are subject to audit by the state. For instance, in the issue of rebates, Mr. Chairman, which we've discussed, there's clauses in our contract that allows the state to bring in a third party to audit to make sure that we pay them 100% of any and all rebates that we get. We do that, and they audit it, and we've been found to do that without any problems whatsoever. The open records, Representative Prince, Representative Houston, I think y'all really hit on the key points here. If we have this contract and we're required to turn over this information and make it public and make it available to our competitors, the next time this contract is up for bid, they're going to know everything about us. We've totally had to open the kimono, give them all our data, and how we're going to fare in a bid. Representative Houston, if they see your cards in bridge ahead of time, you're not going to win very often, and we're not going to win. And what's going to happen is you're going to see a lot of, I can't say for certain, there's going to be a lot of hesitancy, I would say, for a company like CVS or anyone else to come in and want to bid, because if you win, you've got to turn over that information. And then your competitors see it, and we're competing not only in Georgia, we're competing all over the country. And that's going to be used against us in 50 states. And that's something that, frankly, we should not be subject to. The result of that is you're not going to have good competition. As Mr. Wethington pointed out, you're not going to have good competition for RFPs. We compete hard now under RFPs. These are not sole source contracts. We have to compete. Prior to us getting the contract, Express Scripts, another PBM, had the contract. We had to compete against them. We won, and we got the contract. I don't know what you're going to see in terms of competition if these provisions are enacted into law. Just to echo the point that Cash made, last year the General Assembly passed Senate Bill 313, which requires a huge amount of data for us to provide. So much data that the effective date of the requirement gave us to July 1st of this year so we could get it all together. You don't even have that information yet, and yet we're back here now asking for more information. And this information, as I say, goes way beyond the pale, and you should not be a private company, or a public company for that matter, should not be required to provide all this in a public setting. I would bet that all of you, when you were campaigning this past year in your districts, you did not get in front of your local chambers of commerce or the Rotary Club or the Kiwanis Club, the business people in your district, and say to them, you know, if you're going to do business with the state, I'm going to go to Atlanta and pass a law that makes you turn over all of your information, your quality information, your profit information, everything, if you want to do business with the state. I would imagine you probably campaigned on Georgia is the best place in the nation to do business for the eighth straight year. And I submit to you that a bill like this and a law like this is going to damage that reputation seriously. It sends the wrong message to companies that want to do business with the state. It's going to chill competition, and that's going to result in higher costs to the taxpayers and the consumers. So I would urge the committee to withhold action on these bills. Let's get the data and the information you requested last year on July 1st, see what that brings. If there are other questions after that, we can talk about that. But we haven't even received that, and here we are trying to ask for more information, and very sensitive information at that. Mr. Chairman, thank you, and I'll be glad to take questions.
Sure. Chairman Knight.
To my friend, and I know we've disagreed over the years on this, but I do take, quite frankly, a little bit of offense back to your comment about Georgia and trade secrets. I would tell the business community at large, there's not another product that I know of in which the underlying cost is unknown, and that there's not choice, and that you can't see it. Invariably, just like a gallon of gas, you've got commodities, you've got the services that go in, and you trace it up, and you can watch the price of gas go up and down with the market. And to come here and to equate the non-transparent healthcare market in which you can't see anything, in which all of the costs and all the contracts are totally hidden from a point of view of not only taking and hiding the cost, hiding, quite frankly, the cost of the vertical integration that we're seeing that is going on and what you're charging out through the 20-something pages, if you want me to go into it, of CVS, healthcare and their financial statements.
Yes, sir.
Okay? I take great offense to that, because we in Georgia are the best state to do business, because we are about a free market, and we're about the market and choices. And I would tell you to equate healthcare costs, not only in Georgia, but the United States, okay, to all of a sudden trade secrets. The trade secrets is you're in the middle of everything, and you're in the middle of the providers, and you're in the middle of the plans. And what is coming out of that is what cannot be seen. And I really do, from a perspective of painting a broad stroke that calls Georgia, me, or any other representatives trying to undo business, I take great offense to it. And I think the analogy, and to speak to the trade secrets where everything else in our marketplace is driven at a market, there's choices.
Yes, sir.
Okay? But to do this, and there's also multiple people that you answer to. This contract you enter into not only affects the state, but it's the people who are also the beneficiaries who are seeing, costs come out of their pocket. And they've seen it increase and increase and increase and increase, and they don't understand.
Yes, sir.
Because nothing in the middle is transparent. And
Chairman Knight,
certainly the underlying cost is being hidden. And I would tell you, what other business in our nation has seen under this kind of non-transparency, this opaque cloud, this complex, convoluted system of legal contracts with subsidiaries and everybody else, has seen cost go up and up and up and up. And I would tell you there's no other industry except what's going on within health insurance.
Chairman Knight, let me just respond if I could, Mr. Chairman. First of all, I certainly didn't mean for you to take offense to anything I was saying. I'm simply stating the facts as I see them, and I think they speak for themselves, number one. Number two, to use your analogy about the gasoline and the price of gasoline, if you pull into the gas station and you see the price of gasoline, certainly what it costs to get it from the oil field to the refinery, et cetera, plays a part, but also what plays a part in that price is what it costs to run that service station, that store. You're not allowed to walk in and demand that the service station owner say, you know, you're charging $2.45 per gallon. I want to know what your costs are. What are your expenses? What is your profit margin? How much are you making this year? Because I want to know that about that price of gasoline. You're not allowed to do that. And it's just what you're talking about here.
But I also have a choice to go to the filling station next door that may be selling it for $2.40 instead of 5 cents.
And the state has a choice. They have multiple PBMs that compete under the RFP for the state's business. So it's not like there's no choice. And I would also say to your comment that the costs are hidden. Again, we have to provide reams of data to the State Health Benefit Plan and to DCH doing our work. We are subject to audit under the provisions of the contract for rebates and the like. So to say we're hiding things, respectfully, I would disagree with that point as well. There's competition. The bottom line is this bill is going to result in less competition, which is going to result in higher prices for and accomplish the exact opposite of what you're trying to accomplish here.
How many years have the audits, the rebate accounting audits, how many years has that been in place?
Since we've had the contract since 2018.
2018. So is there anyone from the department here? Just curious if it could be helpful at some point, not necessarily in this hearing, I know we're about done, but to look and see how the current system is working, to see how the reporting is. Have the audits been done that are already allowed? No, as you mentioned, but at the same time, is there some increased transparency in addition to last year's bill that I know the net profits you mentioned, claims payment, quality information? Is there some increased transparency you'd like?
Well, the transparency you passed last year, we're certainly going to comply with. Yes, sir. We'll certainly comply with that. And I would again urge the committee to say, let's hold off on these two bills. Let's get that, see what that tells us. If there are any gaps that you think are important, we can talk about that. But to ask for all this information, proprietary information, trade secret information, and specifically declare that it's subject to open records to our competitors and anyone else, we just don't think that's good public policy.
Thank you for your testimony. This is a hearing only today. We do have a little question when we look at the red ink increasing in the hundreds of millions of dollars, whether this is an issue that we can afford as a state, as responsible representatives, to see go that heavily and doubling even, or actually it's up 10 times as much in 2022 and then doubles again in 2023. That's the issue we're going to have to. That's going to be a challenge for us to look at. Is are there ways? Can we afford to wait and do things gradually? I guess at this point, I think we're. Did you have any final comments?
Nope.
Okay. At this point, we'll. Oh, yes, sir. Yes, sir.
I apologize. I did not get in time to sign.
Feel free. Yes, come on up. Just introduce yourself and then.
Thank you, Mr. Chairman. I'm Boyd Pettit, Georgia Link Public Affairs Group, and represent PhRMA, the Pharmaceutical Research Manufacturers Association. We've reviewed 447 and 448, and I think the comment a minute ago of the budget language for several years that has gathered or allowed you to gather information. From our perspective, and I heard you mention this word a minute ago, aggregated. Some aggregated data. We understand collection of aggregated data. If it's not aggregated, our concern is disclosure, obviously, of more proprietary, more personal information. That's just the concern on our part. And I know as you work through the budget language, if I'm not mistaken, Chairman Parrish can correct me, but it was aggregated data being collected. So that's the only comment that I'd like to make, Mr. Chairman. I'd be glad to answer a question if I can.
Sure. Chairman Hatchett.
I don't have a question.
Okay.
Oh. All right, thank you.
Thank you
for your
for letting me
testimony.
speak, and I apologize for not getting here in time to sign.
No, glad to have you, thank you. Chairman Hatchett.
I guess we had a little bill last year that involved and covered a lot of this, and it would have provided this information to a commission. Would you still be opposed to that commission seeing this information?
Keeping it somewhat confidential
Or either
and not open trade.
Anybody?
Well, I think, if I'm not mistaken, the fact that the bill contained that commission is the reason given for the governor's veto of the bill.
It was the makeup, it was the makeup of the commission.
Part of, because it was
Right,
on the commission.
right.
Right. But if you're talking about keeping it non-public, I think that's an improvement. I'm not sure it solves all the problems, because we still got problems, some of the information you're asking for, could leak out, so to speak, but I think that's an improvement.
That can happen anywhere.
Yes,
but-
I think that'd be an improvement, Chairman.
Okay.
Yes, sir.
Thank you, Chairman. All right, we're, this is a hearing only. Thank you for your participation today. I believe we're adjourned. It was a good,